Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Jason Van Tassel. Dr. Jason Van Tassel is a San Diego native and attended San Diego State University, graduating with honors with a Bachelor of Science in Biology. Dr. Van Tassel attended Georgetown University School of Medicine, located in Washington, D.C. He graduated with honors in 1997, being admitted to the Alpha Omega Alpha Honor Society. He was then accepted into the Head and Neck Surgery Residency program at the University of Arkansas for Medical Sciences. Upon completion of his residency, he joined the faculty at the University of California, Irvine in the Department of Facial, Plastic, and Reconstructive Surgery, completing a fellowship in 2003. He is currently board certified in ear, nose, and throat and facial, plastic, and reconstructive surgery. Dr. Van Tassel practices medicine at Washington Township Medical Foundation in Fremont.
Good afternoon. So today I'm going to be discussing some new treatment options for the treatment of chronic sinusitis. Many of you may have suffered from sinusitis at some point in your life. It's a very common affliction. Therapy's changed quite a bit in the last 40 years. We do things quite a bit differently than we used to, and so we're going to be discussing some of the things that we see now that we didn't used to see, and discuss some of the treatment options that we have, including specifically the possibility of doing what's called a balloon sinuplasty, where the sinus just gets dilated surgically, that can even be done in the office. Across the street, and I've been there for about 7.5 years and see patients 5 days a week. So if any of you would like to make an appointment going forward, I'm certainly available for sinus and other issues as well. So just as an overview with regards to sinusitis in general, each year there are about 37 million people who get afflicted with sinusitis alone in the United States, and it incurs about $8.6 billion in healthcare costs per year. Of the people who are afflicted, there are about 58 million days of restricted activity or people missing work because they're sick, and it accounts for about 1 in 5 antibiotic prescriptions given nationally. Of the patients who are treated for sinusitis every year, there are about 525,000 patients who undergo sinus surgery every year in the United States. Of the symptoms that most patients complain of, that includes heavy purulent drainage, pussy, gross, green, yellow boogers from your nose, facial pressure and fullness, chronic nasal congestion, fatigue, facial or dental pain, and headache. These are the most common symptoms of sinusitis. In terms of the classification of sinusitis, there are 4 different types. The first is acute sinusitis, which may manifest as a result of just a common cold. It will typically last longer than the common cold, which is caused by a virus, and can last up to 4 weeks. That's called acute sinusitis. Then there's recurrent acute sinusitis, where people have just sort of a predilection to get the same thing over and over again, and that's defined as more than 4 episodes of acute sinusitis per year. There's subacute sinusitis, that is an infection that goes longer than your typical acute sinusitis, but then finally peters out before the 3-month period. And then for those patients who have sinusitis for more than 12 weeks or 3 months, that's classified as chronic sinusitis. And patients who get to this point are much less likely to result in or to achieve a clinical response with medication and medical management alone. In terms of the things that cause sinusitis, there are a number of bacteria that are commonly seen. The most common with acute sinusitis is Streptococcus pneumoniae. This is the same bacteria that causes fluid in children's ears, otitis media with effusion, very commonly causes tonsillitis and so forth. It's one of the most common bacteria that affects the upper air digestive tracts in both kids and adults. There are a couple others that are important here: Haemophilus influenza, Moraxella, Staphylococcus aureus. And interestingly, when you look at acute sinusitis versus chronic sinusitis, what we see is that Staphylococcus aureus rises to the top. And patients who go from this acute bacterial sinusitis, they tend to have a predominance of the Staphylococcus aureus. Some of the other ones are still seen, but the orders are a bit different in patients who have chronic sinusitis. The way that we manage sinusitis, this is just a treatment algorithm that looks at both chronic and recurrent sinusitis. We always start off with medical treatment. And when you go to see your doctor and you have a sinus infection, if you've had the infection for 3 to 5 days, the doctor, especially in the first visit, is going to be inclined to say, look, this is probably a virus. Why don't you give it a few more days, take over-the-counter decongestants, some Tylenol, some Dayquil, NyQuil, Tylenol, cold and sinus, or whatever, and see if it gets better. For those patients who tend to get beyond this, antibiotics is indicated, sometimes steroids, whether it be nasal steroids or even an oral steroid regimen can be prescribed. Saline irrigation, one of the best things you can do in the setting of both acute and chronic sinusitis is to just wash the nose out. And then allergy management. For those patients who get better, we just continue on with these lifestyle management issues, allergy management, continuing to irrigate the nose with saline and potentially a nasal steroid spray if you have allergies or other issues. For those who don't improve, typically we'll end up seeing an ENT, that's what I am. And then when you come to see me in my office, we'll do a more comprehensive evaluation. Sometimes if you've had one course of antibiotics, it's fairly brief, we may treat you with an extended course. If you haven't had oral steroids before, we'll give you some oral steroids. But ultimately, most patients that have chronic sinus end up getting some sort of an imaging study, like a CT scan of the sinuses. I'll show you a lot of those during this talk. So once maximal medical management has been reached, we've optimized all the antibiotics, the steroids, the allergy management, and we've given people antibiotics. If you improve, we just send you out the door and no surgery. But if there's no improvement, then we raise the question as to whether or not patients might want to undergo surgery. And that can include the possibility of formal functional endoscopic sinus surgery or balloon sinuplasty, which can be done either in the operating room or in the office. Okay? This just sort of summarizes the treatment of sinusitis in terms of the medical therapy. The medical therapies typically are antibiotics and steroids. And the limitations of that, of course, are that these medications have side effects if you use them too long, or you can develop resistant bacteria if you're on antibiotics too long. And in some cases, there's some underlying anatomy which sort of predisposes some people to have sinusitis that's not addressed by medical management. And that can only be fixed by surgery, whether it be by office sinus dilation or formal intraoperative sinus surgery. As far as the sinus dilation or balloon sinuplasty, this is ideal for patients that have sort of mild to moderate and even in some cases severe chronic sinusitis, but don't want to undergo the expense or the invasiveness of formal sinus surgery. The limitations, of course, is it might not be able to treat some complex types of diseases such as nasal polyposis, or there are some cases that the sinusitis is just too severe to treat with just office dilation alone. And then the formal sinus surgery is for patients who fail medical management, have more complex sinus disease, that more than what is perceived to be beneficial if treated with just the balloons alone. And this is kind of an evolving thing, because at one point we thought that we can only treat the mildest of sinus disease with the balloons in the office, and then we sort of looked at the studies and looked at the data and looked at what we're able to do with it. And I think what we're finding is that the indications for balloon sinuplasty, whether done in the operating room or in the clinic, are becoming broader, and we're able to treat more severe forms of sinusitis. Disadvantage, of course, of sinus surgery is that it requires general anesthesia. It has a slightly longer recovery. We're talking about days here. We're not talking about weeks. both the office sinus dilation and the formal sinus surgery that's done in the operating room have a very rapid recovery rate. So in terms of the anatomy of the sinuses, this is what we're talking about here. The sinuses there's 4 sets. There's the frontal sinuses, which are in your forehead. And there's the ethmoid sinuses, which sit between your eyes, and the maxillary sinuses, which are in your cheeks. And these are the sinuses that are most often affected. They typically will manifest, if you have chronic sinusitis, as having facial pressure, congestion. This is the lowest sinus, and so it tends to accumulate the most junk. Patients that have ethmoid sinusitis tend to complain of, pain between the eyes and just pressure, sometimes even behind the eyes. And then the frontal sinuses are in the forehead, and the pain tends to localize there. And then there's the sphenoid sinus in the way, way back. And these tend to give patients headaches sort of in the back of the head, but it can also radiate forward and sort of seem like an ethmoid sinusitis as well. If you look back, this is more of a historical perspective. From 1900 to 1980, we were operating on sinuses. So sinus surgery is not new. But what we did is we did an invasive procedure where we made a cut inside the mouth and lifted the mucosa off the front of the maxilla, and then we were able to take out the disease from within. It had a fair long-term success rate of 40%, but it was limited to really only addressing the maxillary sinus. Moving forward, in 1980, we sort of started using these cystoscopes the urologists use and the arthroscopes that the orthopedists had just started to use, and began to do sinus surgery in the operating room, which gave us the ability to see more than just the maxillary sinuses called Wallucta, but also the ethmoid sinuses and the frontal sinus. It was designed to preserve function, and it was a step forward because the old Caldwell-Lux procedure had just stripped out all the mucosa. So you were leaving back behind healthy mucosa, and people were able to regenerate their tissues. And this also allowed us to do this as an outpatient procedure. Some of the earlier studies quoted a success rate of about 70%, but most recent studies quote a success rate of about 90%. There are some risks, as there are with any surgery: bleeding, infection, the risk of orbital injury, vascular injury, and even brain damage, but these risks are quite rare. One of the arguments against functional endoscopic sinus surgery is that it failed to preserve all the anatomy. I think that, as you'll see in some of the slides that are going to be coming up in the next few slides, we have learned that you want to preserve as much of the anatomy as possible. So when we first did sinus surgery in the operating room with the endoscopes, we made big enterostomies, big holes, and took a lot of the sinus tissue out. And over time, we started gaining an understanding that the smaller the holes that you left, the better. And then the last issue that I think that I'd want to dispel is the issue of requiring nasal packing. Most patients, even that come to see me today, have horrific stories. Oh, my Aunt Susie had sinus surgery, and they packed her nose for 3 days, and they pulled it out of her nose, and she bled like a stuck pig, and she passed out, and it was an awful mess. By and large, most patients today who undergo sinus surgery don't have any packing at all. There are still some indications for it if there's profuse bleeding, if the patient happens to have particular bad sinusitis, or if the patient has some sort of a bleeding problem. But for the most part, the packing that we put in is all stuff that is internal, dissolves on its own, is not designed to stop bleeding, but is designed to prevent scarring. So this is actually an example of a traditional sinus surgery. What we're doing is, this is a little shaver device that is much like the shaver at home that you'd use to shave your face or your legs, but it's a swivel, and it's got a little blade which cuts the tissue away and suctions it away. And what this is it's called a microdebrider, and it's taking away the sinus cells. And there are a couple maneuvers that it'll show here, but this is removing the uncinate process, which covers the maxillary sinus, which is right here. And we've learned in the last 5 years that uncinate process should stay because it plays an important function. And we'll show that in just a second. This is a patient with a CT scan that shows that they have sinusitis involving their maxillary sinus, that cheek sinus, and then the sinus between their eyes, the ethmoid sinus. The sinus has a little bit of thickening over here, but is relatively normal. And what you're supposed to see when you look at a sinus CT is that the bone is white, air is black, and all the gray stuff is soft tissue. And in this sinus, you can see relative to this sinus that there's not much gray tissue. It's quite a bit more over here. And then these ethmoid sinuses are kind of full of the thickening of the mucosa, which is consistent with chronic sinusitis. Back using the old style of functional endoscopic sinus surgery, where we took out the uncinate process, which would have sat right here, you can see that quite a bit of tissue has been removed. And some of the function of the sinuses is removed by virtue of taking out that tissue. And in this case, you can see that despite having had all this stuff taken out, there's still some thickening over here in this maxillary sinus. Doesn't show up very well in the scan, but what you see in a lot of cases after traditional functional endoscopic sinus surgery is that the sinuses, the mucus doesn't seem to be able to get out. There continues to be persistent thickening of the sinuses. Clearly something went wrong here. And so we've looked at what it is that could be the cause of this, and there are a bunch of things. Does chronic sinusitis recur? Is it a technical error? Are they overventilated, overexposed? This concept of the mucociliary pathway and biofilm development. And these are all things I'm going to talk about in the next couple slides. So we recognize that there was an opportunity to do a lot to, fix the system and get patients better. And this is just a pathway looking at all the patients who probably have chronic sinusitis that decline annually and kind of just stay in this loop of being sick over and over again. So what we've done is we've taken a new approach to the treatment of sinusitis, and we've gained a better understanding of what was needed to treat it and established and developed technologies that make it less invasive, preserving normal anatomy and sinus function. And so what I'm going to talk about is some of the research, the developments that have happened in the last 5 to 10 years that address these issues. We understand the mucosal cilia, which move the mucus out of the nose and out of the sinus. We better understand the function of the uncinate process, and we understand what's going on in the air in the sinuses. So this is a patient this is a photomicrograph, an electron micrograph, which is a super high magnification, 10 micrometers. And this is normal, healthy cilia, and it looks like hair. But if you have a patient who has damage from infection, you'll see that the infection will wipe out these cilia, and so that area can't sort of clear anything out of there that might get stuck there, such as a bacteria. So when you have mucosal damage as a result of anything, whether it be an infection or a cold, it causes structural anomalies in the epithelium. That means that these hair cells go away and they can't sweep the mucus out. And what also happens is in the remaining ciliated cells that are supposed to kind of push out the boogers, they can't do that anymore and stuff gets stuck. So this is a micrograph of a normal healthy cilia. It's partially damaged and then pretty beat up. And I guess it's pretty obvious that this one's going to do a much better job than this. This is kind of your house falling down here. So reasons for the mucosal damage, there are a couple reasons. Chronic inflammation, which is the sinusitis itself, sometimes allergies, and sometimes the concept of biofilm development. And then there's also the possibility of excessive tissue removal, which I think that used to happen quite often, which we don't do anymore. And then tissue trauma for the instrumentation. And then if you take away too much tissue, you have an alteration of the sinus atmosphere. It's not supposed to contain the normal air that you and I breathe. It actually is different. This is just looking at the uncinate process, which is part of what covers the maxillary sinus, and they found that it has a very high concentration of cilia, much higher than other locations in the sinuses, so that it can very aggressively remove stuff and kick stuff out and clear the nose. And this is where this uncinate process sits right here. This is an uncentered process that's been resected, and in traditional sinus surgery, in order to make that hole, to open up that maxillary sinus, that uncentered process is removed. And I don't do that anymore, and most doctors who've been exposed to the balloon concept and talk to the industry people that are interested in balloon sinuplasty, most of us leave this now, unless there's special circumstances why it should come out. The other concept is the concept of nitric oxide. And this is the stuff that you would put in your mouth if you had chest pain. This is not the stuff that you would inhale at the dentist's office. It's a free radical gas, and your body makes it. And in fact, your sinuses make quite a bit of it. And what they found is that your sinuses make an elevated concentration of nitrous oxide when you have asthma, but if you have nasal polyps, it makes less, and patients who smoke make less. Patients who have some strange conditions like PCD, which is primary ciliary dyskinesia, which is rare, and cystic fibrosis also make a lot less nitric oxide. And these patients are all prone to have chronic sinusitis. So you can look at the sinuses, and they've measured the concentrations of nitric oxide in these sinuses. And there's quite a bit more in the sinuses than there is in the nose and the exhalation, because it just tends to sit there. And it does things. It causes vasodilation. It kills bacteria. It stimulates ciliary transport. And it's been known in the concentration of the maxillary sinus, it greatly exceeds the concentration at which you would stop the growth of bacteria. So if you're removing all the tissues and letting that gas out, you're going to affect the ability of the sinus to sort of self-regulate. So the next issue is biofilms. And I don't want to bore you with too much science, but what happens is if you take away the nitric oxide and you take away the normal ciliary clearance of the nose and the sinuses, stuff tends to just pool there. And that bacteria, when it pools, tends to set up house. And it's not just a bacteria that's living here or there. They develop colonies, and those colonies can be set up so they protect themselves. They can immerse themselves in a gel that prevents the body from reacting to them, and it makes it resistant to antibiotics. And so one of the things you can do, though, is we can rinse the nose out, but you have to get the stuff in there. So overall, the idea is with regards to biofilms are bad. Nitric oxide is good. If you take too much of the sinuses out, then you won't be able to make nitric oxide, and you'll resultingly have biofilm problems, and your sinuses won't get better. So balloon sinuplasty was developed for the specific purpose of preserving more of the anatomy and allowing the nitric oxide cycle to continue and to reduce biofilm. And what it does is it's a small flexible catheter that goes into the sinuses, and we can do this both in the office and in the operating room to open up the sinus without disturbing and removing any of the mucosa and creating any scarring. Minimal bleeding. Most patients are able to return to normal activities in 24 hours. I see patients that I've done that day at the grocery store. People go out that night. People go back to work the next day. These sinus balloons have been around since about 2005. The original iteration was that of a lot of cumbersome X-ray equipment to confirm the position, but it's evolved, and we've got all these catheters now which are for the specific sinuses. This one's for the maxillary sinus, this one's for the frontal sinus, and these balloons go in and sort of open things up. So this is another type of balloon which is all self-contained. This balloon system is made by Clarin, a subsidiary of Johnson & Johnson. This one is made by Entellus, which is a startup here in the Bay Area. But the idea is this, is you instrument the sinus, put this balloon, open things up, and then the sinus can drain without damaging any of the mucosa. This is an actual case, and what you can see here, this is the balloon which extends right here into the maxillary sinus, and you can see the balloon kind of blowing it up and ballooning it out. But we're not cutting anything. This is actually the incident process. And you can sort of see the balloon right here opening up. I had a video of a patient that we took last week that we took on our iPhone, but she didn't bring it in because she doesn't drive. I was going to try to have that here for you today. But The concept being that you can insert these balloons with very minimally invasively. You can do an injection in the office of some lidocaine in someone's nose and dilate this balloon and open up the sinuses. This can be done for both patients who are newly being treated for sinusitis, and it can be even used in patients who've had previous sinus surgery for revision cases. This is a pre and a post of one of my patients that had a maxillary sinusitis on one side, and this is after the balloon was done. You see complete clearance without any disturbance of the natural anatomy of the nose. So what's the success rate? It's about 92% of the sinuses remain clear after 2 years. 80% of patients remain free of sinus symptoms after 2 years, and this is fairly consistent with other forms of treatment of sinusitis. And then the success rate demonstrated that the sinus CT scan remained improved after 2 years. And so I've got a couple slides that are of a study that was recently done that looked at doing balloon sinuplasty versus traditional sinus surgery. And what they found, as their metric that they used was this thing called a SNOT 20, which is a thing that patients fill out. It's a survey that basically determines how miserable they are from their sinuses. And at baseline, the patients who had balloon dilation are in the blue, and the patients that had controlled this regular sinus surgery are in yellow. And they are baseline, they are both pretty miserable compared to their postoperative states. And the patients that had balloon dilation versus the traditional FAST did about the same. So the patients, these are the pre-op patients that had the balloon and the post-op patients, and their SNOT scores went down, which is closer to no problem. And the same thing was over here. Now, where things start to diverge between the two is in terms of the postoperative nausea when you discharge them, whether you discharge them from the office or you discharge them from the surgery center. Patients that had traditional sinus surgery had a lot more nausea because there's more bleeding. Some of that blood gets in your stomach and it irritates things. There's less bleeding that's associated with balloon dilation. And then in terms of nasal bleeding, traditionally, we send someone home with a little sponge on their nose for 24 hours. Take it off tomorrow. The bleeding should be stopped by then. And patients tend to ooze. About half the patients tend to ooze for about 24 hours. Whereas with regards to balloon, especially in the office, much less incidence of bleeding postoperatively. And then if you look at recovery times, how much pain medicine you need, how long you need to take your pain medicine, the recovery time is pretty remarkable. So it takes about 5 days to recover, which in my definition in the world means weaning off your prescription pain medicine and transitioning back to Advil or Tylenol. And for balloon sinuplasty, it's about 1.6 days versus 4.8 days. And this is from the remodel study. I think that in my experience with my patients in my practice, it's a little shorter, but this is a large study that was done by about 10 physicians across the country. The duration of the use of the pain medicine, 1 day for balloon, 2.5 days, almost 3 days for patients that had traditional sinus surgery. And then how many days did you take the over-the-counter medicines? Just a little bit longer for the traditional sinus surgery. So the conclusion that you can draw from this is the recovery time and the duration of taking your prescription narcotic pain medicine is far less, and the surgery overall is much faster in terms of your recovery. So to summarize, I've gone over a lot of things, some of it sort of esoteric and scientific, but ultimately we have a better understanding of sinus function than we used to have, and it's basically changing the way that we manage sinusitis. Irrigation, especially with saline, and sometimes we'll put medications in that saline, is paramount in the management of patients with sinusitis, whether it's acute sinusitis, chronic sinusitis, patients who have not had surgery, patients who have had surgery, because it really helps to break stuff up, wash stuff out. The next thing is we've really learned to better optimize our patients' medical management. In terms of the sinus surgery, we're tending to do more less invasive procedures, and more of the anatomy is spared, leading to improved function. Balloons, which are new, are kind of replacing the traditional sinus surgery in some places, and where they're not replacing it, they're transforming it. So 5 years ago, I would still take out the uncinate process. Now I leave it. 5 years ago, I might have packed. Now I really don't pack. But in either case, I use a lot less packing and preserve a lot less anatomy. And then with regards to balloons, especially, you can do these procedures in the office, which lead to less pain, faster recovery, and decreased expense both for the patient. There's no cost of the anesthesia. There's no cost of the surgery center or the hospitalization. You go home the same day from the office. There's less expense for the patient. There's less expense for the health system as well overall. So with that, that is it. Thank you.